Good morning, everyone, and welcome to the Community Health Worker Virtual Summit. Today, it's nice to be with all of you, and we're glad to have your presence here. I am Michelle Nakarati-Chapkis, and I'm Executive Director at Women for Healthy Environment. Our organization is a nonprofit organization headquartered here in Pittsburgh, and we focus on environmental exposures that impact public health. And we do that through the lens of doing community programming and technical assistance and advocacy in communities in which we work, focusing on environmental justice communities. We have three main programs. We have a program that focuses on schools through our Healthy Schools PA program, which just had its summit, 5th annual Healthy School Summit, 2 weeks ago. We have a Healthy Early Learning Initiative, and then we have the Healthy Homes program, of which the Community Health Worker Summit falls under today. Unhealthy housing and substandard living conditions and dangerous environmental exposures, equitable and affordable housing opportunities all impact a family's ability to live, learn, grow, and play, and recreate together in communities. We know things such as poor air quality and lead in paint and pipes, inadequate ventilation, and pest infestations all lead to putting people at risk in their homes for health problems like asthma and allergies, respiratory conditions, and other chronic diseases. The Healthy Homes program provides relevant and reliable, science-based, evidence-based information to empower families to make changes in their home and to create a healthier environment and become advocates for policies and regulations to protect everyone from environmental health hazards in the home. We provide free community-based workshops this year in a virtual setting and also hands-on activities. We emphasize education and affordable solutions for families to maintaining healthy homes. That gives you a little bit of insight into the programming that this initiative falls under. And I wanted to just take a brief couple of moments to really also speak to some other issues that are facing us and relevant today in the times that we're in. Our organization was one of 30 that across the region signed a commitment to doing better in the year and how we are going to face the pandemic and racism, structural racism across all the sectors in which we work. So I'll just pull a couple of excerpts from that statement that we all committed to so that you all can see and hear a little bit about where the environment and health community are coming together for change. So during the pandemic, the people of Southwestern PA have learned much about who we are, who we want to be, and the need for unity and leadership in the face of loss and uncertainty. The turbulent time presents a unique opportunity to rebuild a stronger, more resilient region together. A responsible recovery from COVID-19 and from our legacy of racism begins with addressing the essential challenges before us and planning our best next steps. Now is the time to build a society that is truly founded upon justice for all and comes from understanding and respecting the interconnectedness of all people, our health, our environment, and our prosperity. For example, as we have seen from CDC data, COVID-19 is widening existing racial gaps in health equity. The pandemic has also demonstrated the stripes and stressors encountered by our frontline heroes every day, and that includes each of you. We can't thank you enough. But please know that we have heartfelt and utmost gratitude and appreciation for the work that you do each and every day. Honored here today am I to welcome our supporter of this conference, the Highmark Foundation, and its CEO, my dear friend, Ms. Yvonne Cook. She is president of the Highmark Foundation and responsible for management and direction of the foundation. For more than 30 years, Ms. Cook has volunteered her time and expertise by serving on many boards and committees. She has received numerous awards for her service to the community, including the Leadership Award in the area of business and industry by the YWCA of Greater Pittsburgh. She is one of the founders of WE and served many years advancing our mission of creating healthy communities. So thank you for that as we celebrate 10 years this year. And as we celebrate 10 years, Highmark Foundation celebrates 20 years of improving the health outcomes of residents and communities. They support programs focused on chronic disease, family health, and service delivery systems, provide access to care, and establish broad and strong community impact. Through this work, the foundation demonstrates new and sustainable ways to solve health problems and illustrates the effectiveness of early intervention and preventative health programs, such as the one we are doing here today. Yvonne, thank you so much for your support and your friendship, and congratulations on your 20 years. I'll turn it over to you.
Thanks so much, Michelle. I am so excited to be here today. As Michelle mentioned, I'm a former board member and co-founder of WE, and I'm so excited to see WE progress the way that it has over the years. They are doing extraordinary work. Today's forum is just one of many that they have exceptional forums, thought leadership forums that they have hosted over the years with exceptional speakers, educational programs, and just an opportunity to connect around environmental health the way that they have over the years. I'm also very, very appreciative of the staff. They're an extraordinary group of people, a wonderful team. They do excellent work in the community. And we actually have the WE organization come in and provide some consultation to the Highmark Foundation related to its school grants program as well. And so we're very, very grateful to WE. I love the work that they do. I'm very proud of them. My time on the board was extraordinary, and I continue to follow them everywhere I go, and I stay in contact with Michelle. And so thank you, WE, for what I know will be another exceptional thought leadership forum today, because we have such wonderful speakers, and the information that we're talking about disseminating to individuals participating in today's virtual summit is going to just be wonderful for everyone to have and to be able to share with others and to grow and learn from what the speakers have to say. Michelle asked me if I would introduce our keynote speaker. I shouldn't say keynote speaker, I'm sorry, Dr. Bryant-Stephens. You are the first speaker of the day. And you are our first speaker. I'm not trying to put any pressure on you. I'm looking forward to your presentation. I did a lot of digging about you on the World Wide Web. And so I'm delighted to be able to introduce Dr. Tyra Bryant-Stephens, who is a board certified pediatrician at Children's Hospital of Philadelphia, CHOP as it is known. She's also the medical director and founder of the community, the Community Asthma Prevention Program, CAPP. So between CHOP and CAPP, CAPP is a program underneath CHOP. And so it's wonderful to have her here today. Her work is community driven. It is evidence-based research in asthma and environmental triggers. That work that she has done through the program has led to national recognition of what they are doing in the space of children and asthma in the environment. Through the Community Asthma Prevention Program, which utilizes community health workers to implement asthma intervention in underserved communities, their work is something that draws so many from around the country to reach out to Dr. Bryant-Stephens around how to address, support, and understand better what needs to be done in this space. I was also blown away as I was doing a little bit more research about Dr. Bryant-Stephens, and that is, she talked a little bit about on one of the videos, her passion for this and how it started. And she talked about how her husband and her daughter both have asthma. But in addition to that, when she was doing her training, her first patient was an individual who had asthma as well. And so that really triggered in her the desire and the commitment and the passion to go above and beyond and really understand how the environment impacts and how through intervention, through medication, through being compliant about the treatment pattern for addressing asthma has really been something that has been really important and helped so many lives that she has touched. But in addition to that, there's all these environmental triggers that you have to keep at the forefront of what may trigger an episode. So I'm really excited to hear from Dr. Bryant-Stephens. I also came across a couple of videos you might want to go out and take a look. One was titled Impact of Interaction Toward Clean Energy for Children Who Have Asthma. There's a lot of data in there related to the number of people who have asthma in the United States, the number of children impacted by asthma. And the other video was the role of indoor air pollution in asthma as well. And so I think those two videos are really important. I had a chance to look through them and review them. And I'm just really, really excited about your work, Dr. Bryant-Stephens. You have You're an exceptional pediatrician. We have some pediatricians here in Pittsburgh that I'd love for you to meet. You may even know some of them. But I think what is really, really important is what you bring to the table around environmental health. We've had these conversations at WE about making that direct connection between environmental triggers or environmental issues and how they actually impact our overall health. And the more that we can keep building those linkages, the better we're creating additional evidence that they are directly linked, and that we need to create new policies, new practices by which to affect and address those things. So I will stop there. I think that you are exceptional. I can't wait to hear your presentation today. And I want to introduce to you all Dr. Tyra Bryant-Stephens from CHOP and CAPP, and all the work that you have done. Thank you so very much from the bottom of our hearts at WE, and for all those who have learned so much from your work and your team's work. Thank you so much. Dr. Tyra Bryant-Stephens.
Thank you so much. That's like the best introduction I've ever had. So I really appreciate it. So kind of you. I'm happy to be, and actually honored to be here with all of you today. When I asked Michelle who the audience was, and she said community health workers, I thought, well, this is a great group, and it's the people who I hang out with all the time. So I'm totally excited to be here. So today I'm going to talk about the CAPP program and how community health workers are central to all that we do. And I'll just start with this picture. If you look at the back, this is actually where our hospital is, and this is our community. And you can see just how it looks and how different it looks. And one of the things that, as I started this journey 23 years ago, one of the things that struck me at the time, I was a medical director of one of the first off-site health centers from CHOP, and it was right in the heart of West Philadelphia. West Philadelphia, we'll talk a little bit more, but even though we have the beautiful CHOP buildings and University of Penn buildings, we're surrounded by a lot of poverty. And as medical director, I made sure our doctors knew the latest medical treatment, how to approach asthma, but our patients still ended up in the hospital emergency room. And I started to think, what is going on? What are we doing wrong? What are we missing? So I decided to kind of take asthma to the community and try to listen and learn from the community to understand where the gaps are. As you all know, asthma is the #1 chronic disease in children, affecting 7 million children in the US, affecting over 20 million people in general. And Blacks are 3 times, and Blacks and Hispanics are 3 times more likely to have asthma, 2 to 3 times more likely to be in the hospital emergency room for asthma, and 4 to 5 times more likely to die from asthma. So that's a serious problem. We have made some strides. We've closed some of the gaps, but we still have a ways to go. So today I'm going to talk a little bit about how we got there, about the context of West Philly, and then I'm going to go right into how we have deployed community health workers to really address the problems. So as I got into this, I realized that, housing, education, food, income, structural racism, social supports are just as important, if not more important, than healthcare. The CDC says only 20% of health outcomes is due to health cares. So long before social determinants of health was a buzzword, I realized that all of these impacted that. And unless we figured out a way to actually change the dynamics of how our children who are living in low-income environments are served and their environment is improved, that we really were not going to make a difference in asthma outcomes and the disparities. So when we started the CAPP program, our goals were to increase, and still are, to increase asthma knowledge and to improve self-management behavior. So one of the things that I realized that as providers, I can give a lot of knowledge at the time that I meet the family, but I'm not really changing their behavior unless I teach them how to actually incorporate and integrate what I say into their daily lives. Also improve quality of life. We also want to equip members of the community to become neighborhood asthma experts. And that's how we kind of evolved to the community health worker model. We want to promote asthma safe home and school child care environments. And ultimately, we want to reduce the burden of asthma on disparate populations. So just to give you context for West Philadelphia, so 21% at least of parents, caregivers, I'll show you a study we did that shows more, but overall 20% of the caregivers report their children have asthma. At CHOP, we have about 1,300 or more children hospitalized due to asthma per year, over 3,000, 3,000 to 4,000, depending on how bad the flu season is, who are admitted to the emergency room. Several years ago, I kept hearing that, oh, asthma is about 14% prevalence in Philadelphia. And I didn't believe that because of my practice, where it seemed like everyone had asthma. And so our community health workers did a major feat, which is they went door to door to over 2,000 homes, and we did a questionnaire. And what we showed is what Aristotle said years ago. If you tell me how a man dies, I can tell you where he lives. There's truly a big difference depending on the zip code and the prevalence of asthma. So when it says positive here, it's just the number of people who says doctors told them their child had asthma. In terms of the children who had symptoms, there were several more, 5 to 7% more who had symptoms that may have been asthma had not been diagnosed. And if you look, you can see a direct correlation between poverty and the number of children with asthma. In CHOP, and so this was door to door, and this was 2010 before we really ramped up our electronic health record. So when we were able to really look at CHOP, so I should tell you that our inner city practices cover over 50,000 lives. So we're talking about big population. We see that 26% of our children have the diagnosis of asthma, and about 20% have active asthma. So the core interventions by the CAPP program, by CAPP, has been evolving over the years. So we didn't start with this at all. We started with classes. We learned from the families in classes what they needed, and then we kind of spread out from there. But these are the core interventions, and we'll talk about all of these: home visits, classes, education, schools, and primary care physician training. Our stakeholders are many. First and foremost are our parents and caregivers and children diagnosed with asthma. We also have clinicians. We have school district, community agencies, faith-based organizations, housing agencies, as well as public health professionals in there. Just to give you the science around this, and we have been honored to contribute to the science, we find that community health workers are uniquely placed to link communities with the health system, and they bridge the gaps between health service and hard to reach and marginalized groups. And we talked about early the social determinants of health. So they're able to address those factors and through resources and resource connection, improve outcomes. They're trusted frontline health workers because they live in the community they serve, they look like the community they serve, and they naturally communicate in a culturally sensitive manner. We also have seen in the literature that CHW programs can effectively deliver key maternal and child health interventions in primary and community health care. And we'll talk about how we've integrated them to our healthcare team and how we've provided patient-centered education, clinical home settings. And also we talked a little bit about needs assessment and how they serve as patient advocates. In asthma, we've shown that community health workers are effective in implementing home visits for education and environmental remediation, providing in-office asthma education care coordination, providing case management in the hospital, providing care coordination, resource identification for caregivers, conducting school screenings, and conducting school asthma education. So there's plenty of work for community health workers to help us with because there's lots to do. And this is just a conceptual model, which you may have seen before, but how community health worker delivered environmental intervention can change lives. So it can improve trigger reduction behavior. It can improve trigger reduction asthma management, with social support, increase quality of life. We've seen that it leads to less depression and better asthma management. We also have seen how it improves asthma management and via access to health care. Again, we'll talk a little bit more about that. And with the ultimate outcomes of really reducing asthma symptoms, reducing activity limitations, improving the way medication is used properly, and improving clinical utilization. So in CAPP, we have 3 major roles, and they evolve daily. My team often talks about how my vision never stops. So, but I have an awesome team with a lot of resiliency and just bring a lot of energy to this. So we have community home visitors. So these are community health workers, I say at large. They're not limited to a health care system. They provide home educational and trigger reduction visits to anyone in Greater Health Philadelphia, and we'll talk about the funding source for that. And then we have asthma navigators, and these are the community health workers who are directly in the clinic, but also do the home visits, so they provide that connection. We'll talk a little bit more about that program. And then school ambassadors, which is the newest role. I'm really excited about this role because they are not only able to facilitate interactions between schools and caregivers, they can also help to improve the environment by helping teachers reduce triggers in the classroom. So just to tell you how we think about training, we've been fortunate to actually now train not only our own community health workers, but others, community health workers through our CAPP Academy. And so the way that we do this is we have a didactic session with active review. So there's a lot of self-learning, there's a lot of interaction there with our team. Our community health workers are integral to even our training. They meet with our new hires or new, if we have community agencies we're training for, they meet with our trainees to go over all of this. I meet with them to do Jeopardy sessions. And then we have mock sessions, and the mock sessions are where they teach the classes that they're going to be teaching in the community, and they get a lot of feedback, and they have to then be shadowed in the field before they get their wings and they're independent. So here's our core model with home visits, and our community health workers are here. They're connecting home and with community resources. So this is not connected to the clinic. And in this core model, they provide one-to-one asthma education through 4 asthma education classes. They assess the child's bedroom and live in general living areas and do simple environmental interventions in the child's bedroom. They give supplies to facilitate interventions. They inspect the rooms, they follow up visits, and the education is reinforced at each visit with teach back. So these are the visits that we do, and I'm not going to read through all of these, but just to show you, we have 4 visits, and with each visit is an education and environmental remediation component. We do script the classes. We realize as community health workers get more and more comfortable, they're not reading the script, but we are very scripted because I want to make sure that the knowledge we give to everyone is the same, and it's not, and that everyone gets the core pieces. But our community health workers are also, helping families make their homes safe and asthma friendly by showing them strategies for reducing pests, strategies for reducing dust and mold, and also strategies for reducing tobacco smoke in their home. The last visit, we talk about school issues. We discuss connection to community resources. At the very first visit, we do a care coordination goals for the caregiver to see what their concerns are and what they want to meet by the end of our interaction with them. And so at this visit, we also talk about whether we've met those goals and what else we need to do to meet those goals. So the second role is the asthma navigators. And as you can see here, they're connecting the home with the school, and also, the family with the healthcare, and the family with community resources. So they're bridging this gap here and here. And so they make those still make those home visits, but in addition to that, they are in the office. They many times will meet the families for the first time in the clinic. The providers can refer to us, they can write an order, and we know that. So if they don't meet them in the clinic, we check our inbox and we can talk to them that way. And the nice thing about this, they can bridge the gap with communication. So if they're in the office at the time the patient comes, they can actually sit in on the visit. make sure that the patient understands and the caregiver understands what the provider is saying, bridge any communication gaps. If they're not in the clinic, they have access to health records so they can see what was provided that day, and they can also bridge that gap when they meet with them. Again, we do care coordination goals, and they provide resources, and they can assist with scheduling. They actually schedule patients in our electronic health record for the provider, and we follow most of our families for a year. So the components, again, are care coordination, education, and navigation for the Asthma Navigator program. And I won't go through all of these, but you can see that it's richer than just the education, environment trigger remediation, because now we're adding on-site care coordination and also navigation of resources. We do have families who don't feel comfortable, for example, with the specialist, and the community health worker can go with them to that visit and bridge that gap. We also have an asthma population health team that's multidisciplinary, a CHOP, and community health workers the asthma navigators are really relied upon to provide essential information when we have children who are very sick. So this is just a quick look at one of our studies and outcomes. So we had a little over 250 participants. Most were African American. Most mothers were the main caregiver. Most 100% were Medicaid insured. And in fact, that was one of the eligibility criteria. And you can see some of them had issues in their neighborhoods or in their home. And so after a year of following them, as I just described, you can see that we really made some significant progress through this interaction with reduction in the rescue medicine, which means they're not having as many asthma symptoms, with reduction number of symptom days, symptom nights, slowed activity, school days missed, and work days missed. And I showed this just to show you how powerful this role can be. And then if you look at healthcare utilization, you can see we made a huge difference. This may not seem like a lot, but this is a lot of money, between 4 and 1.5 emergency room visits and 2.5, and that's over the population 250 in a year. So when we look at the cost, this actually saved about $10,000 per participant in our program. So we learned some lessons, mainly that it works, and that they're not one of the kind of unexpected findings is that navigators actually ended up promoting asthma guideline-based care in the home and the office. So for example, if a child was on a medication and needed another medication because they weren't controlled, the navigators were often the ones who said to the provider, this child's not controlled, I was just in their homes, should we consider increasing, and I really believe they're taking their medicine, so which is important. Should we think about considering, and providers have been really grateful to have them part of the team. This value added has been acknowledged and supported. The insurers now pay us for our asthma navigators visits. So our next is this big research project we're doing now. It's called the West Philadelphia Asthma Care Collaborative, which is funded by the National Health, Lung and Blood Institute, NIH Institute. And we're doing a randomized controlled trial of 600 school-aged children who live in West Philadelphia. And I have to say, I didn't start this out as a researcher. That's not, I'm a primary care pediatrician first. But the one thing that we know, we can't get folks to pay for things that are not evidence-based. So we have to do the research in order to get it paid for. So this was kind of our final, and I apologize for this slide, but our final, I shouldn't say final because I always think of something else, but one of the main things for connecting the dots. So we talked about having an asthma navigator. We talked about having a community health worker, and then we added the school ambassador. And our hypothesis is that the synergistic strength between the connections in the home, healthcare, community, and school will reduce the burden of asthma management. And we're doing this through placing community health workers in both the clinical, school, and home setting to bridge gaps, identify beliefs, and enable caregivers to deal with social stressors. I should say that we always, all of our research programs is guided by a community collaborative of those folks that I mentioned at the very beginning. So we did a year of planning with them. We talked to parents, we talked to school nurses, we talked to providers to find out where the gaps are. And then once we understood what those gaps were, that's when we designed this research project. And so you can see now we're adding community health workers all around the circle. So this is a very complex thing, and I'm not going to spend a lot of time. I will just say that we randomize children into 4 groups. P plus S plus is when you have a community health worker as an asthma navigator and a community health worker as a school ambassador. The other ones get 1 or nothing. And we randomize them because we want to see, and we actually want to prove, I want to prove that having community health workers in both the school and the community setting and clinic settings what we need, and that it's actually cost effective, that we actually show that doing this really will lead to improve asthma outcomes. And so again, I'm not going to belabor this. We've talked about the asthma navigators already, and the school ambassadors we'll talk a little bit about soon. And so we're going to compare the effectiveness of the primary care and school interventions. So that P plus S plus group to improve asthma control, reduce asthma symptoms as compared to the other groups. And we're going to look at what things tend to affect us. So for example, is it that the children, we find out that children with higher BMIs do worse even if they have both a community health worker in the school and in the primary care center and home. So we're looking at those kind of factors to see if we can identify which group would best benefit from this kind of intervention. Here's our outcomes. We're looking at asthma control. We're looking to see if their symptom days are reduced, their school absences are reduced, their emergency department visits are reduced, hospitalizations are reduced, and cost savings. We're also looking at, we're implementing evidence-based interventions, meaning that this is research that says it works, but sometimes the research is in a very sterile setting. So we're going to the community, and we know once you get into the community, life happens. It's not a lab, it's a community. So we're going to see if we're able to implement these evidence-based interventions, and if we have to change them and adapt them to the community, what that actually looks like. And ultimately, we want to have the school district, for example, adopt this project and fund this so that it will be sustainable. So here's where we are. We have we actually have about 40 more families now since we've done this data, but we're about 9 years. They have to be school aged. Most are male, most are African American. You can see 1/3 of our children are really obese, and then about half of them are not controlled. You can see here in the year prior to them enrolling, 1/3 had hospitalizations. Most kids with asthma don't have hospitalizations. So I always have to say that because I think sometimes in the world we live, we think everybody goes to the hospital, but most kids do not. Half of the kids had emergency room visits, and half of them have this medicine, the oral steroids that we give for attacks. And unfortunately, 12% of the children end up in intensive care unit. And why this is important is because the more of the utilization, the hospital emergency room visits and steroids they have, the more likely they are to die. They increase their risk of dying from asthma. So we started our school-based asthma therapy with our school ambassador. And this is huge because one of the things we know in asthma is that only about 40% of the children take their medicine all the time. They're controlling medicine to prevent asthma attacks. And a lot of this is because caregivers have so many competing stressors, getting everybody out to school, in the morning, and remember to give 1 child or 2 children their asthma medicine can be difficult. Also, there are other barriers just with, timing, support. So what we wanted to do is remove the morning dose from the caregiver's load by having a community health worker work with a school nurse to administer that control medicine once a day. And I will tell you at the beginning, the school nurses thought this is one more thing we have to do, and they didn't want to do it. Now they love it. And we've seen really, just to show you that we were shooting for 75% of the children getting their medicine every day. And you can see that we have 90% of the children who are getting their medicine every day. And this is because the school ambassador, who is a community health worker, is actually coordinating everything even to getting that child into that office at the right time. Also coordinating to make sure the medicine is there. Coordinating with the school nurse to make sure she has time, because our state laws are that the nurse has to administer the medicine. So this has been a huge effort, and we're really happy about how well this has gone. And so just the feedback from this so far, and we're nowhere close to being finished. Like, as you saw, we had about 500 enrolled, and we have to get 600 enrolled. So we haven't done our analysis yet, but just the feedback has been really positive from the primary care providers. They appreciate everything the community health workers do. They believe that the community health workers relieve some of the stress surrounding the time limitations of physicians and nurses. And they believe that community health workers provide important support to families with transportation, scheduling follow-up appointments, and increasing engagement. And they emphasize that a team-based approach in primary care is essential, and community health workers should be a part of that team. So that's really awesome for us to hear that, and certainly supports what we believe is necessary. And then the school nurses, so the school ambassador also do open airways classes, so they educate children. And the school nurses' response has been overall positive. They saw changes immediately once the kids went through our classes. Now, another nurse noted that it was helpful to have someone on site who actually knows the triggers, can help actually educate the scholars about what they can do to prevent asthma flares. And then on the school-based asthma therapy, getting their controller every day, one of the nurses says, you know, I could not have done that on my own. And the other kind of, again, side benefit that we really are not measuring, the school nurse commented on, was that I couldn't get parents to turn in documents and do things. And this program has definitely helped with that. And they just say, just building that communication bridge has really helped them get everything they need from the parents. So they've been really grateful for that. Some of the overall challenges and lessons learned has been that community health workers do walk that tension, and I'm sure you all can tell me better than I can tell you, of juggling being a community asthma expert, a community expert and an asthma expert, meaning they know what it's like to be in the community, but they're bringing asthma expertise to the community. And we always give them decision-making power in terms of how long to follow non-adherent family, what stays private between them and the caregiver. Also, community health workers may not have experience with data collection, so we do a lot of training and oversight around that. And then community health workers are autonomous and may spend much of their time alone. So we have found the need to have team building activities, which has been almost impossible with COVID, but we're still trying. And we also have a very transparent means of monitoring their activities and holding them accountable. And we always, anytime we get a positive feedback, we make sure community health workers get it first, because they're the ones that are really doing the work. So in terms of our sustainability, currently our home visits are paid by the Medicaid managed care, and the structure is per visit rate. It includes provision for visits and supplies. It's allowing for community health workers to be fully supported by CAPP. And this model has now been disseminated throughout Philadelphia by the Philadelphia Department of Health, the Room to Breathe. So we train the community health workers, and now they coordinate with other hospitals and other parts of the city to implement our model. So in summary, I'm almost done. Here's kind of where we are right now, and we've evolved over the years. So we do the core model, the navigators, the WEPACC, which I just described. The last thing I'll talk about is the community, the CAPP Plus home repairs. The CAPP Academy I've already talked about. So this is our newest thing, and I love it. Over the last 15 years, I've really just been struggling with the fact that even though we are able to provide indoor supplies, interventions, there's some really gaping holes that we have not been able to deal with. So we have started something called CAPP Plus, which is asthma self-management, education, environment mitigation, which we've been doing for years. But now we actually partner with a home repair agency to do home repairs, structural home repairs. I'm not going to go through all this, but we do address pest, mold, dust, and extreme heat and cold, and VOCs, and with our home repair agency. And the community health worker role in, we call it CAPP Plus, is to identify and recruit families to help them complete the application, to go through the home with the homeowner to determine which pairs are needed to mitigate triggers, to attend the initial inspection, final inspection with contractors and families, and to serve as an advocate for the homeowners throughout the process. They're integral. Initially, we thought we could just hand off these families to the repair agency and move on, but we found out that our caregivers really want our community health workers to stay involved through the entire process. So they now are part of the entire process of these home repairs. So where we are now, we've completed about, I think 67 homes total, and we're on par to finish 100 by the end of the fiscal year. And I'll just show you some of the things we've done with exterior repairs. This is a kitchen repair, and you can see we've installed a ventilator hood. We've given them cabinets so they don't have things all over the place. We've given them a new unit here. This is the bathroom before and after. You can see we pretty much improved the floor and the vanity, as well as, I think, a new toilet unit. And this is a floor repair. This is what we see in most of our homes in terms of carpet is really in really bad disrepair. And so we're replacing the carpet with vinyl flooring. And then in the basements, we're dry locking them. Many of our homes are built at the turn of the last century in the late 1800s. And so these wet basements is a common problem. As you all know, wet basements produce mold, and so we are dry locking the basements. So I'll just conclude by saying that community health workers are valuable. You know, they are the core of what we do every day, and they help us reach hard to reach vulnerable populations in a cost-effective manner, closing the gap between healthcare and families of children with asthma. We fund them now by insurers, so that's really awesome. And we feel like the WEPACC actually getting in schools may be the final step in connecting the dots. I think the beauty of the community health workers, they function in many capacities as educators, care coordinators, and connectors. And we hope that our findings and all that we do will advance the fight to eliminate asthma disparities, because there should not be any asthma disparities, and achieve health equity. Thank you. Any questions? I don't know if we take questions now or not.
Dr. Bryant-Stephens, oh my goodness gracious, thank you. And I can see what 23 years of investment has done, and as well as all of us here attending today. It's an incredible amount of work, and the holistic approach is just amazing, and so much, gives us so many ideas about what we can do here and locally, but for all the folks who might be joining from across the country. I know that we have somebody who had to wake up at the wee hours of Pacific time joining us, but thank you so much for sharing all of the lessons learned and great insights into this program that you've launched and maintained and sustained over the years. And we look forward to the next 23. We've got 5 questions here in the Q&A, so let's address those. The first one was, how have home visits changed at CHOP due to COVID-19?
Yeah, I almost put a slide in that, but we weren't supposed to talk about COVID. Yeah, we had to go to virtual visits. So we actually, so as you all know, the state, the governor had a red, yellow, green kind of process. We in Philadelphia use the same kind of thought process, but we have a little bit we're more restrictive than maybe the governor's plan is. So initially, everyone went home. Our community health workers quickly transitioned to virtual visits. I was actually on vacation when everything shut down, and I immediately thought, oh my gosh, how am I going to keep these folks working? Because one of the things I always think about is, if this stops, what happens after that, right? So for our team, and because I'm a clinician, I was immediately told that, you know, you have to start doing video visits. And I was like, well, if I can do video visits, they can do video visits. And we were a little worried that the families wouldn't be willing to take their phones in the home, because we do home inspection, right? And so we were a little bit worried that they would not want to do that. But they've been more than willing. We really, I mean, obviously we give them a choice. They don't have to do it. But people have just been really open to doing that. And then when we moved, as you know, kind of when the surge was over, we moved back to full home visits for a while until the surge started again. So we're back to virtual visits.
Thank you. Thank you for answering that. There's a question about getting a little bit more, taking a deeper dive into the stakeholder component. How were you able to get buy-in from all the stakeholders that you mentioned? Did you put together any environmental and public health communication to do this?
Yeah, so when I started this 23 years ago, it was just me and a nurse. And we quickly realized that we just didn't have the knowledge we needed to know, even though at that point I had been, I guess, in West Philly for about 7 years. I didn't grow up in Philly, I grew up in North Carolina. So I don't, I didn't know the community like that. So when we started doing our community classes, we started recruiting folks. So we would offer free community classes and we said, but we want you to sit on our community board. So that's kind of how we initially got community. And as we expanded to, folks heard kind of about us. We had the RWJ Foundation project in Philadelphia called Allies Against Philadelphia. At the time, I didn't realize we were the only game in town. I just assumed somebody else was doing this in the other part of the city. But when we started meeting with all of them across the city, we realized that CAPP was the only folks doing that. So we were asked to then apply for grants to spread it to North Philly. So we did that, and every community we've gone to, we've recruited people for our board. So now if I have a plan to put a grant together, I always take it to our collaborative. We don't call it a board, our collaborative, and say, this is what I'm thinking. What do you think? What's the feedback? What should we do? And we try to work on it together. And I would say the other way we get buy-in is that we participate with them. So it's not just them helping us, it's us helping them. So for years, for a couple years anyway, I was on the school asthma planning committee, and that was my time that I donated because just as they're a partner to me, I want to be a partner to them. So we tried to make it two ways.
Is the CAPP Academy available to CHWs outside of Philly?
It is. I will say the part that's hard to do, which we might be able to do virtually now, but the part that's been hard to do has been the training for the home visits. So typically everything else you could do virtually, but typically once you've mastered and got to the field training, we have our community health worker travel with you, our lead trainers go with you until they feel like you have it down, and that's when you get your wings. So that's the part that we haven't quite figured out, but we haven't ever tried it virtually. So it's certainly something someone else has approached me about, and it's something we're thinking about. How can we do this? So certainly willing to pilot to see if that would work, but we have not been able to do that piece. So as you had a community health worker from Pittsburgh come to us, and she actually came to our site, spent a couple of weeks, and this is obviously before we were doing virtual things a couple of years ago. And that part we could do, but working out the field training, us getting our community health worker to to Pittsburgh was something that just never materialized.
What are some of the remediation resources for the families who are facing housing issues as a large contributing factor to their asthma?
For our core program, the resources we give, are you talking about the environmental resources? I assume.
Well, this is specifically to the remediation resources that you started talking about and showed in terms of how to go in and make those home renovations.
The renovations, yeah. So we have a limit per house. We spend about $15,000 per house, and so we do roof repairs, we do floor repairs, we do kitchen repairs, bathroom repairs. But it's all around the triggers, because obviously some of these homes we could spend $100,000 in to get them. It's not HGTV. That's what we tell everyone. This is not HGTV. But we are trying to make it livable so that the families can use a bathroom. I mean, for goodness sake, and use a kitchen and not be exposed to like the gases from the gas stove, right? Because we're actually giving a ventilation hood. And I will tell you, the one thing that has surprised me is how nobody has a functioning ventilation hood or fan. It seems like that's one of the core things we do. We give them vinyl flooring. We give them really whatever they need. We've recently had to close off a Bilco door. That's those little doors outside to the attic, to the basement. So it's really what they need.
And is that 15,000 allocated per household? Is that then paid through the insurance provider?
No, so this last piece of CAPP Academy is still being funded by CHOP. So originally we had a grant with Rebuilding Together Philadelphia through the Bell Foundation, and we did 30 homes with them. CHOP then began to see the value of that and has done a launch initiative called the Healthier Together initiative, where they're investing in the community. So now it's evolved to CAPP Plus, and we are fully funded by grants in the hospital. I think it'll be, I've never, even though other people disagree with me, I've never believed that the insurers should really carry the entire brunt of repairing homes. I think it's a public health issue, and I think there are many people who should participate in that. So ultimately, I'd like to figure that out, like how do we get people to believe that? But to be honest, we're still doing the analysis of the first 30 houses, because we have to follow them a year afterwards. So I can't even prove anything yet and give the evidence yet, except for I know we've made a lot of happy families. You're muted.
There, sorry about that. Thank you for that response. You know, we think about all the different resources and nonprofits that have these, you know, in Pittsburgh, Rebuilding Together, Habitat for Humanity, United Way in terms of connecting with contractors. So it has us thinking a little bit more about how we can touch and collaborate with all of those different home programs that are available. Yeah. Thank you for that. So how did you get insurance payers to start reimbursing for the Navigator visits? And how are the components of the CHWs also funded?
Yeah, so the way we got it, I will say for years, well, after the first 3 years, I went to the insurers and said, look at what we're doing, we're saving your money, and nobody was interested. And so I would do that every year. So about the 6th or 7th year, maybe, I finally said to one of my colleagues in the MMCO world, well, what is it that you really need? Like, what is it going to take for you to fund this? And there was a missing link. Prior to this, we had been totally community oriented, meaning we were not connected to CHOP or anybody could refer to us in the whole community. But, you know, it makes sense now to me that MMCOs is per member per month is how they think. And so they needed to see us connected to an entity, a clinical entity, where they were going to be able to see the return on investment. So once we changed that, that's when we evolved to the Asthma Navigator program, where the community health worker actually became a part of the healthcare team. That's when, I mean, really a year into it, they were willing to pay for it. I showed them some results, and we hadn't even finished our study, but they were like, okay, now you show me what I need to see in order to pay for it.
Thank you. And then our last question that's been posted in the chat is, did your CHWs go through the Penn Center training program?
No, we were there long before Penn Center. We've been for 23 years. I think they've been around maybe 10. I don't know. But yeah, so we have our own, as you can see, we have our own program. And the Penn Center is really more clinic-based and home-based. So I'm not sure how much home visit training's there. And I don't want to speak out of turn because I haven't asked in the last 3 years, but the last time I checked, there wasn't any home training. So we are, I think they do valuable training though. So I definitely think it's worth going through, but we don't send our community health workers just because we have the system.
Have you the in-house ability, and it's very tailored and specific to the needs that you're all addressing in the community.
Yeah.
Okay, wonderful. So I don't see any other questions in the chat. I think we've been able to get through all of them. Thank you so much.
Sure,
it has been an absolute pleasure having you. Yvonne, would you like to have any closing remarks for Dr. Bryant-Stephens before we move on to our break?
So just a couple things. Thank you so much, first and foremost. I think the work that you have been doing, I'm in healthcare. I do philanthropy. And the work that we invest in with nonprofits, we're looking for outcomes. And we're looking for evidence-based practices, and we're looking for outcomes. And you have been successful through the community health worker effort to get the outcomes, knocking on 2,000 doors, making sure that they're connecting with people directly. I mean, that's really critical. I mean, if you're in the community health worker space, being able to have that direct relationship with them, and for that household to be able to share where they really are. They might go in for one thing, but it turns out to be some other things as well. I think is critical, and that you can account for that. And then the intervention becomes this evidence-based practice that I think is really important. So those are the things I have to tell you as a funder that we look for. So when I looked at some of the stats that are in the bio, you've had some great outcomes, and my board and myself would be, and my team would be extraordinarily pleased to see that kind of not only effort, but impact at the end of the day, because that's what's critical. Are we keeping people out of the emergency room? Are we, you know, all of those things. And if we are not, do we need to course correct in a way that will get us to where we really need to be? Because at the end of the day, we really are trying to help people. You know what I mean? We really are trying to impact the lives and the health of individuals in underserved communities, in all communities, but in particular in underserved communities. So thank you for today's presentation. Thank you for your thoughtfulness. I just think that what you're doing is really, really good work.
Thank you so much. It's been an honor to be a part of this. I'm always happy to support any work with community health workers, because they're critical to what we do. So thank you guys so much.
Thank
You're
you.
welcome. Thanks, Michelle.
So many lessons learned here, and you know, that is where one of the things that our organization takes pride in, is that we try and connect with the people all across the country. Unfortunately, there's somebody right in the Commonwealth that is doing great work that we can really emulate and get these lessons learned and put into practice here on the ground. And so we are so grateful for Dr. Bryant-Stephens sharing her story of her 23 years, and goodness gracious, they've really moved the needle there. So thank you everyone for your great questions as well. Thank you, Yvonne, for opening us up this morning. I hope that you'll be able to spend some time with us today.
Yeah.
At this point, we are right on time, which is exciting, which means that we can now, here's our overview of the day. Just as a reminder, it was in the chat, but I did want to remind folks that we are recording this session so that we can take all of these lessons learned and share with others as well, and broaden the reach. So I wanted to make note of that. We do have a poll here that I will put up. So if you can answer the poll before we take our 10-minute break. We recognize there is such a thing as Zoom fatigue, and we are very conscious of it. So we want to break throughout the day. We want you to go and, you know, grab your cup of tea or coffee, or go ahead and check your email real quick that, you know, something might be buzzing on your phone or on your computer. We recognize that. So we're going to give you 12 minutes here to go and do those things that you need to do. Take your bio break. But first, please just real quick, this poll is up on, we want to get a sense of who's with us today. So please identify what best applies to you in terms of whether you're a community health worker, whether you are working for or leading an organization that utilizes the CHWs, whether you don't have any affiliation, and then there might be other. And if there's other, share with us who you are. We'd love to learn, and put that in the chat and make that available. Feel free to use that chat as a networking opportunity as well, so that you can connect with others. So with that, I will pause. It's 9:59. We ask that you all come back at 10:10, and then we will have an amazing community panel. So we will hear from 5 community health workers who are all doing something different in communities here and have a different perspective to share. And that will be introduced and moderated by Mike Bowersox. So please take a 10-minute break and come back, do your stretches, take your deep breaths, get into a great mindset to join us in 10 minutes, and we'll pick up where we left off. Thanks so much. Good morning and welcome back. It is 10:10. Hope you all had an opportunity to step away from the computer and stretch. As I mentioned, we are thrilled to be able to have a community health worker panel here with us this morning. I'd like to introduce the moderator for the panel, Mike Bowersox. Mike has had the privilege of essentially talking at times deeply with people for more than a decade. He currently directs the Root of Health CHW Collaborative and the Connections for Health Initiatives with Southwest PA AHEC, and is a practicing mental health therapist. In each of these roles, he has been invited into people's lives, learning together with some while being there with others to navigate traumas and seek some healing. Mike has worked with and advocated for the homeless and marginalized, provided crisis intervention and prevention services for adults with severe and persistent mental illness, developed cancer survivorship and support programs, and when in need of being humbled, attempts to share with others what he has learned along the way. Mike, it's so great to have you join us with all of the exciting work that's underway in Southwest PA. So I will turn over the mic to you and have you introduce our great panelists that are here with us this morning who will share their perspectives.
Thank you, Michelle. Thank you. It's really wonderful to be here and to be invited to be part of the conversation with you all. Can everyone hear me okay? Am I coming through all right? Okay, good. Always important to check, right? And I want to get to introduce everyone. I guess I feel impelled to at least share. You might see me bouncing some for those who are watching, and this is my adaptive way of sitting in front of computers a whole bunch lately. So I'm sitting on a ball that you may, I don't even notice that I bounce anymore. So, you know, hopefully that's not too distracting. But yeah, thank you again. And here I'll just kind of jump in and do a little introduction for all of the panelists that we're going to be talking with today, and then kind of get into some of the questions in conversation. So the first person I'd like to introduce anyway is Germaine Gooden-Patterson, and she works with and joined Women for a Healthy Environment as a community health worker in December of 2019. And as a CHW, Germaine's work is focused on assisting families who have children with asthma and air quality in the Monongahela Valley, in the communities of Clairton, Duquesne, and McKeesport. And through her environmental justice work at Women for a Healthy Environment, Germaine is part of many collaboratives, including VCAN, which is the Valley Clean Air Now, where she sits on the steering committee. VCAN is a local grassroots organization whose mission it is to fight for residents of the Mon Valley who continue to suffer from severe health, economic, climate, and environmental injustice by galvanizing the community to take action through local politics, grassroots organizing, community building, education, and community health initiatives. It'll be great to talk with you, Germaine. Lily Gori is with the Consumer Health Coalition, and Lily was born in Mendoza, Argentina. In 2002, she moved to Pittsburgh with her family to start a business. For over 10 years, they served the community with their Latin flavors and culture. After her mother retired and returned home, Lily started to work in the nonprofit sector. She provides education and outreach on state-funded programs, as well as helping people to have access to public health. She is a bilingual certified assister and community educator and currently working with the Consumer Health Coalition. In the last few years, she has created a strong relationship with the Latino community. She expects to continue to grow these partnerships and continue to help them with all of their needs. She is currently working towards certification as a community health worker. Gloria Riviera with the Lehigh Valley Health Network. She is a certified community health worker in Allentown, PA. She is a certified medical interpreter, award nominated for Friends of Nurses, Health Heroes Award recipient, Hello Games speaker certified, co-authored abstract presented at the American Public Health Association. She's created and directed 2 Spanish memory cafes, and she is the part of the PA-CHW Certification Advisory Board and Steering Committee which helped to facilitate and develop the CHW certification process here in Pennsylvania. Jamie L. Santana, and Jamie works with the Valley Health Partners. She began her career as a community health worker in September of 2009, when she had the privilege of attending the East Central PA Area Health Education Center's first ever community health worker training in Allentown, Pennsylvania. She is a community health worker for Valley Health Partners, a federally qualified health center lookalike associated with Lehigh Valley Health Network. And Jamie also serves on the Pennsylvania CHW Certification Advisory Board Steering Committee that helped develop the state certification process. And Georgette Evans with Allegheny Health Network. Georgette is a CHW with a street medicine program with a Center for Inclusion Health at AHN. And she has received years of working and serving in the community for those in need of support and resources. She has been with PSAN, Western Psychiatric Institute and Clinic. She has been part of a community treatment team with the CORE program and POWER programs. However, currently in her role as an ambulatory CHW with AHN and the Center for Inclusion Health, she has been in this role for 3.5 months, and it has been a joy working in this type of setting where she gets individuals living on the streets who are in need of support and resources. So thank you all. Thank you all for being here. It's great to to meet and talk a little bit more today. And I'm wondering if it's a helpful place to jump in. I'm curious, maybe some of the others on the call are curious as well. Like, how did you get involved in this work? What brought you here? I don't know. I hate to call on people, but maybe I'll just pick someone like Germaine. Like, how did you get involved in this? What brought you to this line, to doing this in your life?
Well, I would really say that I was called to do it rather than me searching for it. It found me. I'm a people person. I love people. I worked in the health food industry for 23 years, and it was time for me to go. I wanted to leave, and so I put it in the universe. And 5 years later, here it is, the position. To be honest, I didn't even know what a community health worker was. But when this position was presented to me by a friend, I looked it over and I said, that's me. That is me. That is something that I've always enjoyed, working with people. I've always wanted to work in the community. And so it was perfect timing. And so here I am. A year later, almost exactly a year later, here I am.
Yeah, that's wonderful. What about others? How did you all get into this work?
Okay, I go next. Thank you first for the nice introduction. And let me tell you this, I have been helping people since I remember. I remember back in the days when I was young, well, not that back, but when I was a lot younger, I have this passion inside of me of helping others. Like, to me, it's a big satisfaction helping people. And I started working until later on, I found out that this is something that people do as a profession. There is a real job about this. I do come with a lot of experience working in this field. I love people. I love to provide services. And my goal every single day is to help others. I found out that I am community health worker, not only when I'm working, but also on weekends, on holidays. I have family members, I have friends. Sometimes I even provide resources when I am in the market and people need something. So to me, it's a pleasure to assist others. So I love what I do.
That's great. Thank you for sharing that in a wealth of experience. I see Jamie raising her hand. Yeah, go for it.
So I spent my 20s delivering packages, and it was finally time to move on, and I got unemployed, and a friend of mine told me about a training through CareerLink for CHWs. And so I was the first cohort of CHWs through AHEC, and a friend of mine called me, like Germaine, and said, hey, you should go through this training. And I was like, all right, well, let me just go. Went, took the training for about a month. And I'm like, I have no clue what I'm doing because I have nothing to do with health. But as I took the training, I learned about myself, things that I never knew. And as I learned the skills and everything, I learned that, wow, I actually do have a passion for my community. I live in my community, I play in my community. I learned so much that I never knew that I had the passion for. And well, here I am 10 years later, still doing the same thing, and the passion just seems to grow. And it motivated me to go back to school and now get a degree in social work. So, you know, if you have the passion and you learn it and you do what you have to do, hey, it kept me in my community. I'm still doing what I'm doing. And who would have known, you know, a person who delivered packages would have grown this far, you know what I mean? So who would have known, you know, packages, health, you know? So I'm grateful for it, you know?
And, you know, many, many people grateful for you as well along the way too.
Thank you.
I'll go next. So I work as a navigator right now, or bad sister they call it now, and community educator. And I work with a lot of other nonprofits and partnerships, and then I get referrals. And even though I have heard of the word social worker, community health worker, I not necessarily knew what it was, you know, really. And then talking to a friend, that's all you guys, probably the same thing. She said, well, but that's what you do, you know, that's basically what you're doing. Because I start, besides doing the access to the healthcare and filing, you know, filling out the applications for the insurance and all that, I started to do other things. And then if I help one person, especially like in the Latino community, they will tell another one and another one and another friend. So I started getting, you know, people for the same thing. So, you know, she said, well, that's what you're doing. So why don't you go and get certification here? There, you know, there is a program you can go that I didn't know about it. And that's how kind, you know, it all started.
Yeah. Knowing people who know people.
One of those sunny days.
Thank you, Lily.
You're welcome.
All right. Georgette, you might be on mute. There we go.
Here we go. What led me to becoming a community health worker was back in Philadelphia, I had a therapist who thought it would be good for me to work with people in the community that needed help and resources. And that's what led me into all the other roles in my job that led me into community health worker through a friend who I used to work with on another job. Had told the program manager, like, I have an awesome person, this is the person. So here I am, community health worker. This role is, because my role is on the street, providing care to people that are homeless or street homeless. It's a different role and I enjoy it. It's a challenge at times, but I enjoy it all. So here I go. I'm here.
Thank you. Somebody, your therapist saw something in you. Were you aware of what that person was seeing with you at the time?
No,
No.
no.
Oh, that's beautiful. And,
Yes.
you know, things align and it kind of worked. And so, I mean, in Georgette, if it's all right, there was kind of a segue into something else that I think many of us are curious about too, is like the different roles of CHW. And Michelle mentioned that, is that, you know, each of you on this panel kind of feels a little bit of a different role in what you're doing. And you've mentioned about that your role as working as kind of street outreach and reaching homeless populations.
Yes. My role is like, we go out into camps. We go to, like, we service people that live in camp or street or rough sleepers, as we call them, sleeping in park, abandoned houses. And we service these individuals. But also, one of the challenging of serving these individuals is that they can be here today and gone tomorrow. A lot of them, for example, I had two individuals needed to see a dentist, made an appointment, went back to see them, and they already hopped the train and left. So there's where one of our, you know, my barriers is, you know, serving individuals and hoping that they stay put in long enough for me to give them the service that they are asking for. But I enjoy every bit of it. I have the lived experience. I want to share that with y'all. I'm from Philadelphia, and I've been homeless and had all the challenges that I see the individuals that I serve. And so I enjoy doing this job, helping, and as I look at it as my peers.
Mm-hmm. It's a to the bone thing for you.
Yes, yes. Providing them. Yeah.
No, thank you for sharing that. And
Yes.
that is something like, you know, that adds a layer of meaning to being a part of the community that you serve, right? That you know that lived experience.
Yes. Yes.
Yeah, thank you for that. I'm curious about for others. So what are the roles that you all play in the different, as a CHW, in the different things, and, you know, some of the overlap that we might see in some of the kind of unique experiences given what you all do?
Yeah, so my role is, it was wonderful to hear Dr. Bryant-Stephens earlier. So my role is specific to children with asthma and air quality. As you read, I'm in the Wand Valley area, working with 3 particular communities of McKeesport, Duquesne, and Clairton. I reside in Clairton. So my role is just asthma, children with asthma, families who have children with asthma. Yes.
Okay. All right, thank you. I'm going to try to speak a little louder. I know I can be a little soft-spoken, so I'm going to try to speak a little louder. Thank you for that heads up. Gloria, I see you raising your hand. Yeah.
So my role is a little bit different than hers. Right here, my role is to connect patients and family members to a healthcare systems. I keep the community healthy and safe. I advocate for family and patients. Ongoing support and advocacy. I also identify patients' needs to minimize chances of chronic disease by providing education. I also complete the social determinants of health assessments and connect patients with the community resources. And right now, because of everything is happening, I also assist patients and the community to live with the new norms of COVID-19.
All right. Thank you, Gloria. Yeah, Jamie.
So my role is with the Allentown Children's Health Improvement Project. I work with moms that are pregnant and children under the age of 5. My specific role is I work with the American Psychological Association with the ACT Raising Safe Kids program. And so a part of what that is doing the ACEs, doing the protective factor forms. We do a couple home visits, and then we kind of assess where they're at. We do parenting skills, child development, find out, you know, what's going on with child's behavior, link them up to early intervention, we might get other services involved like nurse-family partnership, but we teach on, you know, parenting skills and what are things that they were brought up with versus what are they going to teach their children, how different that's going to be, how we can change those things. And then we set some goals, you know, what are better behaviors. We also, because of COVID, myself and Gloria were actually in the same office. Because of COVID, that kind of has died down a little bit because we have to do it through video. We've been helping behavioral health specialists with referrals and doing social determinants and assistant social workers. So it's been a joy because they've been able to see the quality of what community health workers do. So it's been a value this COVID season. So they've been really relying on community health workers a whole lot more. So we've kind of been popping out more. So it's been an added value to our work during this time. But yeah, so that's my main focus, parenting skills and child development.
Thank you. Thank you.
I'll go next. So I'm not in the role yet per se. You know, I'm working towards getting the certification. But my hopes is to be able to continue helping. At least my focus will be probably the Latino community. That's the community that I know by culture and from where I live. And so I have the hope that I can continue helping them to make their life a little bit better. You know, I know what barriers they have, especially related to language. So that's what I hope that I can contribute with this new role.
Yeah. And you've seen even in your current role now how big of a barrier that can be for a number of people.
Yes.
Yeah.
So it's like one thing leads to another. I'm sure I will be learning other things, but you know, until I get there, for now.
Right. Thank you. Yeah, and I guess that there are a number of barriers that the people that we serve or we anticipate serving that face, you know, and Gloria mentioned the social determinants and how many of, you know, the different aspects of that can be barriers, can be challenges that people face. Whether in this current role or in a role similar in the past, what kind of barriers have you faced, maybe personally, or what kind of barriers have the people that you meet with, have you faced together with them? And what ways have you worked to kind of overcome and work through those barriers that either you or, you know, somebody that you're working with has experienced?
Well, I would say that I can't say that there's been any particular barriers, but I would say that COVID has become a barrier, as it has been for all of us. So in my work, what I've been able to do is just switch, because the ultimate goal is to help people, to help the community. So I've just had to switch, for instance, helping with food distributions. So COVID has been a barrier for all of us, but in the work that we do, you know, it's easy for us to continue to help people who trust us, just to continue to do what we can do in the community.
In a sense, has there been any adaptation that you've had to do in say, around working through COVID and some of the things that happened?
Well, yes, doing virtual workshops, for instance, instead of in person. So it's become the new normal. But in terms of a barrier, thank you for saying that, because it does bring up the fact that people are home with their children, and it is sometimes difficult for them to do a virtual workshop because some people may not even have but one device in their household. So, you know, these are the things that people face that we are servicing in the community.
Yeah. Yeah. What about others? Gloria, I know I'd seen your hand up there at one point. Yeah.
Well, one of the biggest barriers that we had as a community health worker is the medical professionals not trusting the work that we do. At the very beginning, so when community health workers were new to the network, doctors, nurses, therapists, nobody believed that we can do the work that we are doing. So it took a lot of time for us to educate them and prove them that we can do it, and we did it. So we still continue to have, you know, some barriers, like health literacy is one of them, that we need to educate patients and help them to understand that asthma is something serious. So if the list go on and on, like transportation, housing, if the patient doesn't have transportation, it's really hard for us to assist them, because right now we're not conducting home visits that we're supposed to do. And with the COVID, with this pandemic, is another barrier, like she mentioned before, because it's really hard for patients who doesn't have the equipment. A lot of people, you know, they're poor. Patients doesn't have computers. They don't have smartphones. So those are one of the barriers that we are encountering right now.
Yeah. Yeah, Jamie.
I think another thing is with the barriers is you can't see what's happening at home. The other thing is that trust, you know, we built trust, we built relationship. And so, you know, after building trust with our clients or patients, you know, now we can't do any home visits. So, you know, they've relied on us so much, and now we can't do any home visits. And so they're like, oh, you left us. You know, what's going on? And we're like, well, I'm sorry, we can't do any home visits. And here you have months have passed and you can't go to their home. And they're like, they feel abandoned. They feel like that conversation that you've had that were deep, and, you know, that it can no longer be had. And it's not that, it's that you have to move on and keep seeing other clients. And, you know, now they feel abandoned. They feel, you know, that they don't mean anything. And, you know, so now you have to rebuild it again once the home visits are going to start again. So, you know, yeah, occasionally they'll call you, but it's not the same. So now you have to start all over again. And, you know, the providers will call you and say, hey, you know, I see that you had a relationship with them. They're no showing. Can you reach out to them? And, you know, technology, yeah, it's hard. You can't do video calls by using telehealth, the same system. So we use WhatsApp, we use FaceTime, you know, we're unique. So we're different. So we don't go by the medical records. And they're like, how is it that you get a hold of them? Well, we use WhatsApp. What? Yeah, we do. So, you know, but that trust is huge. So, you know, those are some of the things. And CYS, you know, for us here in Allentown, it's, you know, CYS, the children and youth, you know, we built that trust as well. with them. And sometimes they can't even get a hold of them. So they've trusted the community health workers and they've relied on us to get a hold of the family. So that's a little weird too, because they're the ones that actually enforce all the rules, but yet they're relying on us. So that's really nice, you know? So the building of the trust and relationship, it's, you know, but it's a barrier. It really is.
Yeah, and an important one that can't be sidestepped. Because of, if I'm hearing you right, because, you know, they will, that person will pick up the phone for you, right?
Definitely.
Yeah, and just how big that is, where systems after systems may have put these challenges in their way that where things fall off.
Oh yeah.
Yeah, but you know, because you continue to develop that relationship and how it is being challenged now too. Yeah, Germaine.
Sorry. So I would like to bring up another barrier. So I mentioned that my work is in air quality, but a part of that work in air quality is advocacy. So advocacy around advocating for the community when it comes to air pollution. So we sit right in the Mon Valley where there's a huge corporation that spews pollution. So that is a barrier as well when it comes to the health of individuals, particularly to those who have asthma or any other type of chronic disease.
Yeah.
Because the pollution continues, it continues.
Right.
We continue to breathe that air.
Yeah, and the environmental challenges that you know, there's such a long game to those changes, especially when it comes to air quality. Yeah.
And for me, well, COVID would be an understatement, right? But at least we overcome by adapting. I guess that's one of the strengths we have as humans being, and we have learned that we can adapt, and that's a way that we overcome challenges. One of the things that I will mention is that the system is very complex. So I think that that's the biggest challenge for everybody, and I mean, at least for people that are, people that are immigrants probably have a bigger challenge with the language barrier and all that, and not knowing the system as well. And in that complexity, sometimes you have too much information, or you call someplace and they give a different answer. So people ended up being lost. So one of the ways that I overcome that is by helping them through that path, you know. And another thing that I found that is very helpful is the follow-ups. Because sometimes I do things and they said, you know, they get paper in the mail, they're not going to open them, they're not going to read them. So a follow-up is very important. That's the way that I overcome some of these challenges. Just make sure that I, you know, start in point A and I finish in point B. In what I do.
I wonder if I'm starting to hear a theme, especially in this type of way, is the consistency of you being there, or you meeting with the people that know you, for everyone.
I think so.
Yeah. Yeah, Georgia.
I have multiple barriers. Number one is the COVID, because we do get calls from the hospital when someone shows up homeless. And so due to the high rise of COVID, we're not going into the hospital as much. And so that makes a big barrier of making that connection. We have to do it over the phone. So that becomes a big barrier there. And also, ongoing barrier is educating different one. What is our role as on street medicine? Because we do deal with the homeless. with the social worker, and also mainly the social worker, understanding that me, who work under street medicine, deals with homeless people, street homeless, identifying with them, which you consider homeless, not because, oh, I broke up with my girlfriend and I'm not going back there. That in our category is not street homeless. So, I just don't want to be there no more. So I'm homeless. So in just the clarity of when we're being called on to work with individuals, becoming a challenge with the social worker, trying to explain to them, when you notify us, this is our criteria for our program, it's actually people who are all street homeless. So there's where one of my barriers is, and how we've been doing it, we've been talking more about it because this is a new program for Allegheny Health Network. So with the program manager, the doctors we work with, we have been, and the nurses, everybody on the team, like we've been talking about how can we educate the social workers. And so even we included the community health worker supervisor that works in, I don't work in the hospital. I'm part of the hospital, but I work off base. So we, all of us trying to come up with ways to better educate the social workers that are in the hospital of when to contact us. And also our barriers, like we can't go into shelters. Like, even though we do referrals to individuals to go to the shelter, but we can't go in there to follow up because we're dealing with people who has nothing. So that means we're trying to get them IDs, we're trying to get them social, or we're trying to get them Medicare, insurance, medical insurance. So that becomes a barrier. And how we've been doing is trying to connect with the shelters and saying, listen, because then we also got people who do not have phones. Well, we're going to call at this time. We'll be okay if this person could be around at this time. Can you let them know? And can they take this call? So us to connect, to try to get this information so we can try to help them to get their ID. One of the biggest things is not having no ID, not having a social security card, no insurance, all that is but ID is one of the biggest things that a lot of our individuals do not have. Yeah.
Thank you for that, Georgette. Lily had been talking about, the challenges and barriers around systems, and you just kind of beautifully laid out 2-3 of those things that the barriers in these systems, and how some of the ways that you've been challenged to work around those. And I'm wondering a couple of things for you all, and for everyone who is kind of following along and listening here too. A couple of things is, one, I'm aware that there are people joining us today, some who are currently employing community health workers, and others that are looking to do so in the near future. They're kind of putting together programs and infrastructures to be able to bring community health workers into their organizations. I'm wondering if, any of the participants out there, if they have questions for you all, we definitely want to have time for that as well. And maybe somewhat in that vein, what are given the barriers that you have faced, and some of you spoke to overcoming some of those challenges, what are some of the lessons that maybe you're learning, or that might be helpful for the people listening, and watching here today, joining us? Like what might be some of those lessons? And if there are questions out there, please, ask away, and we can kind of fit this into our discussion as well. Yeah, Jamie.
I say your approach is everything. How you approach people makes a huge difference. People read right through you, especially the community you serve. They know if you're for real or not. They know if you're genuine. They know if you really want to help them. you know, they read your body language. They know street smarts. They know what's up. So, you know, you have to be yourself, you know, and community health workers are from the community. They know their community. Um, they know the culture. They know what it's like to be a part of society, you know. They know what it's like to be in poverty. They know what it's like to have a need. So the best thing that you could do is be yourself. There's no reason to be fake. You know, you approach things the way that you know best, you know. Some lessons I've learned, especially, you know, I mean, I grew up here. So, you know, coming into the professional world was tough for me because, you know, I'm Puerto Rican, and around here, you know, I could be ghetto, you know, but, you know, I had to change it up and be more professional, and I had to conduct myself in such a way. And so it was a whole new world for me. And I'm like, oh my God, how am I going to act? And oh, this is a whole new world. So, you know, now I had to flip things around. And so for me, the lessons that I learned is now I have to go to this agency, introduce myself and say who I am. And, you know, what do I do for this community? And so I had to, you know, go and say, hi, my name is so-and-so. I'm a community health worker. I want to learn about the services that you provide. And so my approach had to be a little bit different, and some were resistant, and it's like, well, we offer those services and we don't need your help. And no, that's not what I'm looking for. I'm looking to learn about what you offer, because if I send someone to you, I want them to be treated a certain way, because I have to build that trust, and I want them to be comfortable when they come to you asking for this help, you know. So I want them to trust you. So I want to learn what services you provide. So I say that I would approach these organizations like Eddie Murphy in Beverly Hills Cop. I had to switch my role and approach these people in their way, you know? So I had to be like a chameleon and adapt. So it was a little strange for me. And those were some lessons learned for me. So I had to play a dual role. I had to be a professional, but also think as the client as well. If I came for services, how would you treat me? And what are the steps that I have to take coming to you for services? What are the steps that I have to take? What do I have to bring? What do I have to do to apply? What do I have to, you know, and give me some information, you know, because I want my client to feel comfortable when they come to you for these services. So there were a lot of lessons that I had to learn. It was something new for me, you know, and in that I learned a lot of networking, you know, so that's the lessons I learned throughout the years.
Thank you for that, Jamie. Thank you. I want to pause here, and Hannah, I'm not sure. I don't know that I can see any of the questions from the Q&A. So if there are, let me know, and you know, we can kind of bring some of those in here as well. I just wanted to pause there for a minute as we put that out there.
Yeah, Mike, there's a few. I think, I know Jamie answered one. And I think, yeah, I think you've covered most of them for, yeah, the one that's in there, Jamie already covered. So I think you're good right now.
Nice work, Jamie. You didn't even know it was a question. Thank you for that. So what about others? I know, you know, we're kind of coming up close to the end of our time. Yeah, Gloria, what are some of the?
So one of the lessons learned to me is that, like Jamie said, we live in the community, we play here, and we know our community. But one of the lessons learned is that we need to listen what the patients are saying. We need to listen their needs. Most of the times when the patients go looking for services or they come to the practices, they are talking and the person who is listening, yeah, the person is hearing what the patient is saying, but it's not listening. And to me, that is completely different, because hearing is something and listening is how you're going to react and how you're going to provide good services to that person. And that's all I have.
And listening, and is there another step of that too, is like checking in and making sure you heard what they're saying, right? Like it's
Absolutely, absolutely.
Yeah.
And follow-ups, a lot of follow-ups, so they know that we heard your concern and we are doing something about it. It's not that we just know, we acknowledge that you're going through some situation. It's doing something about it.
Yeah, right. There's a whole other piece to active listening, and it's, you know, the active part is also kind of another question that kind of came through here, and Jamie, this is part of what you answered, but, you know, also to open it up to everyone else, because I think this has been mentioned and kind of talked on and around a little bit here, but there is a balance between working in the place where you live and play and work and worship, you know, of all those things. So how do you all, or what effective ways have you all found of balancing providing these resources and doing these works in the community and supporting these other people, while maybe you're also facing some of your own challenges, issues, things like that? Yeah, Germaine.
So just really having a balance in your life is important. Self-care is important for everyone, no matter where you're working. So I do believe that you have to put self-care at the forefront, because if you're not healthy, mentally, physically, then, you know, you can't even take care of your family, let alone community members. You know, there's a lot of things you can do to balance that, to help balance that. But I would just say that taking care of yourself, making that key, so that you don't get burned out.
Yeah, you have enough in your cup to be able to pour into somebody else's.
Right. So you come first. You really do. It may not feel like it sometimes, but you have to put yourself first. You have to cut off your workday at a certain time. You have to learn to say no sometimes.
That's a hard one.
Yeah, it's a hard one. It is. It is. But just, you know, practicing it.
Okay. I know we're running up on our time. Maybe, you know, kind of, if anyone else has kind of thoughts on this, because I imagine this is a question that might be coming up for other folks too.
For me, because of the individuals that I work with, trust is one of our biggest things, because most of the individuals that are living on the street do not trust anyone. It's up to me to reveal to them, if I wanted to reveal to them that I have the lived experience. So that's a plus for me, because I'm able to reveal that. And when I get to share a little bit about me, to let them know that I've been exactly where you're at, they're more open to connect with me and to trust me to help them. I promise them nothing. And I have to make it clear, I can't promise you nothing, but I'm going to do the best I can. And that is one of the things I do, because I find out a lot of people think because you get these service that you're obligated to have everything that these services give, and it doesn't always pan out like that. And so then you break that trust with them. So I always let them know, I don't promise nothing, but I'm going to do the best of my ability. And what I don't know, to get you there, I will research and find out how can we get you there. So that is one of the things. And my balance is, my phone goes off when it's time to punch out. That's it. I'm really strict on that for the simple fact I've been in this field for a long time, for a good bit. Like working with Western Site Community Treatment Team for multiple years. You have to set that bound. I set boundaries and I shut it off. Like, this is my quit time. Now, the next morning when I cut my phone on, do I have a whole bunch of messages and stuff? Yes. I let each and every one of them know. I will call you. I can't call everyone at the same time, but I will call you back if you leave a message. And I keep to my word. And that's as simple as it goes for me.
Thank you, Georgette. Thank you. That's great. I think, all right, I kind of want to do this. And this came up too, you know, that you sharing like the how, like this is how I practice self-care. I set the boundaries for myself, and and I communicate that with the people that I work with too, so they know what the expectation is. I'm wondering here as we wrap up, if all of you might be able to share one way, one tangible way that you practice self-care.
For me, I love comedy movies. That's my thing.
There you go.
The main black and white. So that's big.
Yeah. What about others?
For me, it's music. I love music, so I play music and I try to relax in different ways. So music is the answer.
Nice. Yeah, Jamie.
I do the gym, and my coworker Gloria. Like I said, we shared 3 offices within a big office. So coming to work, even though we are allowed to work twice a week from home, I choose to work out of the office every day, because we get to see each other. So we have lunch with each other as much as we can. Yes, so we make sure that even though we make calls and do everything, we shout and we're like, lunch, 12, so, because we need to talk, so we vent to each other and we're like, so we have a patient that, this happened, or, or we'll call each other and we'll be like, so this happened. And, so you have to rely on each other somehow, so we're social beings. And so, if you talk to each other that, somebody that can relate to what you're going through, that helps, at least for me. I'm a social butterfly. So, I have to lean on somebody that can relate to what I'm going through.
Yeah, thank you. Thank you.
So because Jamie, she said more than one, I'm going to say more than one. So for me, it is exercise, and COVID has done an amazing thing for me in terms of exercise. So it's exercise, and also sitting in quietness, meditating is a self-care.
Great. Thank you. Thank you, Germaine. Any last kind of thoughts on self-care? So there was a question here that came through the chat, and we didn't get a chance to get to that today. So I apologize, but I'll throw this out to you all, and maybe we might be able to swing back around with one of the participants to maybe pull together and find some answers for her. And the question is, and this is a tough one, that I'm in a small rural community without many resources. How does somebody work with systems and find help for somebody in these small communities? And that's a very big question for me to throw out there without us getting a chance to really address it. And I know we're kind of running past our time here too, but maybe Linda, thank you for that question. And maybe we were able to kind of swing back around and kind of brainstorm a little bit with you, whether it's after this or another day. That is a big big question. And I myself, I grew up in a small rural community, and I understand that a little bit from that perspective. So thank you for asking that question. I'm sorry we don't get quite a chance to get to it today, but I definitely want to be able to swing back around, whether through this group or in any other way to kind of brainstorm it and try to solve a little bit of that with you.
And do you think that there might be one response from a panelist, because we have such a breadth of experience here, that one person might want to take a opportunity to try and help Linda through that?
Yeah, all right, let's throw that out.
Looks like Gloria's ready to provide.
She's ready to go.
There.
Well, I would suggest to check the social media. Now these days, this is something big, and we can find just about anything through social media. You can be surprised when you put out the question out there, the responses that you get.
Thank you. Yeah, that's awesome. That's great.
Have you tried Aunt Bertha? That's one that you can put in your zip code to find out any neighboring areas for you. And also, have you linked up to the certification, the PA certification website, where they actually have a lot of resources on there, different links and whatnot, that you can perhaps get on. Actually going to put my email as well, and I can actually shoot an email to the steering committee, which will put out an email blast to a huge amount of people throughout PA. I don't know where you're at when you say rural. So if you can shoot me an email, that might help. If I can put an email blast to the steering committee, and maybe they can help you.
That's awesome. Thank you, Jamie.
Yeah, I was going to mention Aunt Bertha too, but also reach out to your local council people. It may even get their wheels turning, as to what's needed in the community that you reside in.
Yeah. Thank you. Great ideas. Thank you. And thank you for that, Michelle, kind of nudging us to see if we can't find some at least direction here in this. Thank you all. Thank you for inviting me in to join in and be able to talk with you for the last hour. It's been beautiful. And before we get off, Jamie, or before I jump out of this, Jamie, I have to, your plants are awesome. Those are beautiful back there. So you couldn't leave without at least acknowledging that.
I can't live without them. Thank you.
Those are wonderful. So yeah, again, thank you all so much for kind of sharing your wisdom and knowledge and allowing me to be a part of this. I really appreciate it.
Mike, before you wrap us up and head into the break, I did want to reference that in the chat that we had the Allegheny County Health Department. So for those in Western PA, they knew that we were holding this forum today, and they wanted us to share with them information about the food trust. So that's in the chat for people to take a look at. Oftentimes the food trust and as Germaine had mentioned, she's been pairing up with food distributions or looking for community health workers to pair up their work. And so they wanted to let folks know that the Food Bucks program is available to anyone who receives SNAP benefits and shops at participating retail location. The link is in the chat there under the foodtrust.org. No sign up or enrollment required, locations and more program details there in the link. So that's just a resource for people, and they are actively seeking for partnership opportunities with community health workers. So I did want to just pass that along, and I apologize for the interruption, but I want to turn it back over to you to wrap us up before the break here and talk about some other opportunities that might be available. I think it might lead into nicely some things that you were going to share.
Yeah, so just a couple of minutes here. about, so I work, especially when we're talking about this work, I work for the Southwest PA Area Health Education Center. And some of you have, two of you, right, Jamie and Gloria, right, went through their training program, right, over in East Central. And
Yes.
so, yeah, with Liz and Deborah. And we this year have just, at the Southwest PA AHEC, have adopted and brought on board their training curriculum for community health workers, which was kind of one of the models for setting that state certification. And we're actually just now wrapping up, a couple more weeks here, wrapping up our first round of classes as well. And then we were able to do this through funding we got through the Hillman Foundation here locally to be able to continue offering these classes for the next 3 years. And so our hope and our goal is to be able to reach out to as many people as possible in our region. And I saw some names on the attendees list that we're already talking with, which is really cool about, you know, if talking more about certification and the domains and the criteria that are needed and available. And we're wrapping up this round of classes, but then we're going to be holding another set in March. We haven't set a date yet, but we're going to run another round of classes here in March. Chances are these ones will be virtual again, and you know, probably we will be doing them very much like this in March. So I'll put my email address in the chat here for anyone who is interested or want to reach out and ask questions or just talk. I'm happy to do that at any time. The other piece of this, and so, you know, we called our program, our project, the Roots of Health Collaborative. And that's really what we're trying to build. It's not just a training program, there's kind of two arms to it. And one is definitely the training and certification piece. And then the other piece is kind of community engagement, advocacy, organizing. And part of this is we're starting to hope to pull together a group of organizations and community health workers and, you know, community involved people, you know, that want to help steer how this community health worker coalition takes root and builds here in the region. And we're actually, our first meeting for this kind of community engagement outreach piece is going to be this coming Monday. But it really is trying to get all the input. And I heard some people talking about this earlier too. Really, anything that we want to be able to do here, we want it to have all the voices of the communities that we're trying to pull together and help organize. And I guess that's one of the real big pieces of it, is to create and foster some more alliances in our region and try to get out of our silos, to work with each other, to talk a little bit more, to both empower other organizations, but also people in the community. And I think it works both ways, is that the voices of people doing this work help empower the organizations to be able to do the right thing and make the right calls and head down a helpful path. And so this kind of two-way dialogue, or multi-way dialogue, I guess, helps hopefully to reduce unnecessary duplication of efforts and services. And, you know, if somebody is looking to set up and bring and train and have community health workers be in a particular neighborhood, and another one is as well, let's get those two people talking, right? And how can we best support everyone involved in trying to do this in our region, really from that grassroots level up. So that kind of community organizing piece is kind of one arm of this, along with training and helping people move through the certification process at this state. But I don't know, I think I maybe rambled there a little bit, but hopefully that's at least helpful. I'll definitely put my email address in the chat, so if anyone ever wants to reach out, please feel free to do so. And again, thank you, Michelle. Thank you all for inviting me here and, you know, giving me a chance this morning to chat with you all.
Thanks to Mike and the panelists. You all are amazing and doing incredible work in the communities. We've learned a lot from your experiences, and you all, the beauty of this is that there are mentorship opportunities and roles. So Jamie, thanks by putting your email in the chat and opening that up for people to reach out and ask you questions. And if other panelists would like to do the same, you know, the peer-to-peer learning is so crucial to all of us in the work that we do every day. And so I appreciate all of you having the opportunity to connect with each other and learn from each other as well. So with this wonderful panel, we're going to close out this portion and move to have a quick break again, and we'll come back in 10 minutes. Hang in there with us. We are at the last part of our summit, which is a presentation by Mr. Carl Rush, who is a principal consultant with Community Resources, and he will be able to close us out for the morning and share insights from a national perspective. And so perhaps, Linda, we can get to some of your thoughts there on the West Coast as well, and helping you to navigate through resources. Carl brings a wealth of experience to the table that he can share and enlighten all of us in terms of this work in the sector and where we go from here. So I'm very excited to have his presentation with us this morning. It's 11:16. We will break for 10 minutes, come back, and we will start promptly at 11:26. Thanks, everyone. Okay, it's 11:26, so we'll get back. It's my pleasure to introduce Carl Rush, who will be closing out our summit this morning. Mr. Rush has specialized in policy and workforce development for CHWs since 1996. He has advised CHW policy initiatives in more than 20 individual states and groups of states for Association of State and Territorial Health Officials and other national organizations. He was a lead author on Health Resources and Services Administration's 2007 CHW National Workforce Study and co-lead on the CHW Co-Consensus C3 project from 2013 to 2016. Carl convened the first National Conference on Financial Sustainability for CHWs in 2001 and has recently completed 2 national studies with the CDC on CHW certification and workforce development. He is a member of the National Association of Community Health Worker Policy Committee. Carl, welcome. It's so nice to have you with us this morning.
Thank you, Michelle. Really excited to be with you all. Let me bring up my my screen here, and there we go. And oops, there we go. And share. Okay. Are we showing my slides on the screen now?
Yep, you're good
Great.
to go. We can see you.
Okay. So it's terrific to be with you, and I congratulate you on the program so far. It's really appropriate and very exciting to have the panel of community health workers be the centerpiece of your summit. I agree. It was really stimulating panel. It's really important for a lot of other stakeholders to hear the kinds of stories and insights and wisdom that your panel shared. So I've been asked to speak on behalf of the National Association of Community Health Workers, or NACHWA as we call it. You'll see my picture's a little different from the way it shows on the slide. This is my my quarantine hairstyle. There's a lot happening in this field right now, but I'm going to focus particularly this morning on sustainable financing, which always comes up, and we heard some comments earlier this morning about the process of getting payers to support community health worker activity in an ongoing way. So this is actually based a lot on a policy report paper that we just produced this fall on sustainable financing. Excuse me. I'd like to start just with a few slides real quickly on NACHWA. The NACHWA was launched in April of last year, April of 2019. And it's a very important step in the evolution of the profession of community health workers. And we're very excited about the attention that NACHWA has drawn and the number of organizations that are interested in partnering. For example, the Office of Minority Health at the national level recently funded an initiative on COVID-19 and resilience in communities of color, and they turned to NACHWA as this was through Morehouse School of Medicine in Atlanta, and they turned to NACHWA as a key partner in implementing that that grant. So you can see here the vision of NACHWA and the values that we espouse, and I think it's really important that we emphasize that NACHWA, yes, is involved in policy activity at a national level, but one of our priorities is supporting the development of networks and associations of community health workers at the state and local level. And so I certainly commend to you in the process of developing the network, as Mike is actively involved in, to turn to NACHWA for support and assistance. There are resources out there. And also, I would point out that many of you are concerned about issues around the pandemic and the roles of CHWs in the pandemic. And NACHWA has some terrific materials on that on our website. NACHWA is growing steadily. We have members in 48 out of the 50 states, and the some of the biggest clusters of memberships. I'm happy to say Texas, where I am based in San Antonio, is #1 in membership in terms of state representation. And so please do encourage all of you. I know some of you are already members, but I encourage you all to go to the website and look at the resources that are available. The individual membership for community health workers is $20 a year, and there's plenty to be done there. And we have an active program of webinars, newsletter, of course, and other committee activities, ways for you to be involved. Here's a list of the board of directors. As you can see, these are from all over the country. And as a matter of policy, the board consists of a majority community health workers. And I'm technically on leave because I'm doing some consulting work for NACHWA. But it's a terrific board, and they worked very hard for several years before we were able to actually launch. Another innovation of NACHWA is the ambassadors program. We have 20 ambassadors now, again from all over the country, and they are volunteers who have offered to do outreach in their region on behalf of NACHWA. So this is again, kind of a grassroots movement, and they're a terrific bunch of leaders, and we are hoping to expand that program if we can get more funding for it, because it really makes a difference in having representation on the ground, so to speak, all over the country. We are also very grateful to the initial sponsors, financial sponsors of NACHWA, and you can see here that we have some representation from national nonprofits, as well as the health insurance industry, and this has really enabled us to hit the ground running, so to speak, in building a national program. Also, also commend to you a resource that we just launched this fall, which is Document Resource Center. These are mainly policy documents about the process of developing policies around community health workers. We have a good collection of documents around the policy development process that took place in Pennsylvania, but we have documents from most of the states, about 800 documents initially, and they mainly focus on policy development around certification and workforce development, but we are looking to expand it hopefully in the very near future to include a database on research or evidence-based and employment practices, which is a high demand topic out there around the country. So I will at some point put the link to this, as well as to this report, which is the main thing I'm going to talk about with you today. Both of these are available on the NACHWA website. And this is available to the general public, not just for NACHWA members, since these were federally funded efforts. So the topic of sustainable financing is, Michelle mentioned in my introduction, has been with us for a long time. We had a gathering here in San Antonio in 2001 to talk about the dilemma. A lot of people are very frustrated with all of the wonderful work that community health workers do, and the results in so many different areas, which we'll come back to that point in a minute. And yet most of the work is still supported by short-term grants and contracts. And so this has become kind of a treadmill or a merry-go-round, depending on what you want to call it. I've been using this cartoon from the far side for many years. And it depicts a couple of spiders who have spun a web across the bottom of a slide in a playground. And they're saying basically, we're putting all our eggs in this one basket. We're gonna land this big grant and everything will be fine. But as we all know, that's not a recipe for success. So there's been a lot written about, there's been a lot published about community health worker financing, and a lot of these documents are available on our Document Resource Center. And it really state level studies and some national studies. And our report really kind of is intended to distill a lot of this work to show you what we think are some potential strategies. And so the first question is obviously, what do we mean by sustainable? And we want to be clear about that from the beginning. And what sustainable financing involves is budgeting for the activities of CHWs or CHW positions, which don't depend on applying over and over again for project grants or contracts. And there are various ways of getting there. The two main categories of ways of getting there, haven't been talking this much in a while, so. These can be achieved either through ongoing revenue streams rather than grants. And we'll talk about, for example, Medicaid, which most of you are probably thinking about, which is an ongoing stream of revenue. And finding ways for them to cover or pay for or reimburse for CHW services. And the other big way, which has not been given, in my opinion, enough attention, is getting the employers to cover the expenses of CHWs out of their core budget. In other words, budgeting within their overall revenue without a specific source of payment being dedicated to CHWs. And there are ways of doing that, but as we heard earlier today, that a big part of that is showing the benefit to the payer or the provider organization, the return on investment from using their own money basically to pay for CHWs. And since we are going to be talking about Medicaid, Medicaid reimbursement is kind of the language that we have learned to talk about Medicaid. And because we are getting into other, it tends to be associated with what we call fee for service, or the employer being reimbursed for individual units of service at a certain rate for the services actually delivered. And Medicaid is definitely going in a different direction for the future. But there are ways of incorporating community health workers into these new payment activities. I guess the lesson we have learned, though, is that Medicaid fee-for-service reimbursement may be the hardest way for organizations to get Medicaid to pay for CHW activities. So one of the things I learned in getting into this field is that this stuff is pretty darn complicated. There are really no simple answers. We don't have a silver bullet to offer you that is saying this is going to do it. This is the answer. There are a lot of different answers, and one of the things that I emphasize to people all the time is that the answer for Pennsylvania is probably not the right answer for Maryland or New York or California. That you need to be responding to the environment that you are in and to the stakeholders' interests in your state or in your locality. So there's certain things that we have observed over many years about how this stuff all works. And I'd like to share some of these with you very briefly. First of all, if at all possible, we really want to try to support payment for the full range of CHW roles. and activities. And as you have heard from the panel just before us about the range of things that community health workers actually do, that it's really important to try to keep the payers focused on the benefit of supporting a full range of activities. And the C3 project, which is on the web, has some recommendations for a definition of the range of roles that community health workers play. Secondly, we hear this all the time, but it's really important to emphasize, avoid medicalizing what CHWs do. Community health workers are not clinical providers, and the distinctive things that they do, that you do, since there are a bunch of CHWs on this call today, is to reinforce the importance of paying for what you do best. What really drives what you do, and what really produces the results that you produce. So it's important to keep that in mind and not try to make medical assistants or vocational nurses or whatever out of community health workers. Third, and you will hear this anytime you talk with any of us from NACHWA, is that community health workers need to be driving the process and being prominently involved or in leadership roles in developing policies, which includes payment policies. And so we will continue to enforce that. And that is officially a policy of the American Public Health Association as well. This is kind of a complicated graphic, and we will be sharing these slides with you afterwards so you can look at it in more detail. But this is an illustration of the way, of the range of roles that community health workers play. And on the left, you will see a broader community health improvement strategy, population-based health promotion, that sort of thing. And this covers folks who may very well be in a relatively good health, but you want to keep them healthy. And so that's one level in which community health workers operate. But a lot of what you've been hearing about is on the other end of the spectrum. And this is where a lot of the payoff is for folks like the Medicaid managed care organizations, working intensively with people who have chronic illness, for example, or responding to the needs of the pandemic response currently, which is more intensive support. And it is possible to show financial return to the payer more easily and more dramatically when we talk about supporting the patient who has more complex needs or more intense needs. But we want to try not to focus only on that. Some other key principles. It's important to start from what you would like CHWs to be doing and what employers need to enable CHWs to do what they're doing. And then the strategy is that we suggest you develop is the best available payment structure that'll support what you want CHWs to do. And this takes a lot of networking and understanding, as we heard about this morning, understanding what the payers want. What are their business priorities? And there are definitely ways to do that. You'll hear a lot when we talk about Medicaid about waivers and state plan amendments. And these are definitely ways to get where you want to go, but they are not in themselves a strategy. In other words, you don't start out by saying, what we want to do is get a Medicaid waiver. No, you need to start with what you want to do and find out whether a waiver is a good way to get there. So they are definitely important. We don't have time to talk about them this morning, but in depth, but they are not strategies themselves. And then lastly, that they don't talk about in healthcare financing, they don't talk about financing a profession or adding a profession to the system for the sake of that profession. In other words, advocating sustainable financing by saying, you healthcare system, you should be funding CHWs. That's the kind of language you use in grants. It's not the way people talk about these things in the crazy world of healthcare finance. I mean, it is very complex. And so I certainly, if you're taking on an initiative for sustainable financing, it's important to have people on your team who really understand healthcare finance. I am not an expert in healthcare finance. I've learned a lot, but it is pretty complicated stuff. So you'll hear a lot in this, and before I'm done, I'm going to say some more about it, but you'll hear a lot about Medicaid, and there are a lot of reasons for that. One is that, of course, as we've all heard, that the states are under a lot of pressure to both improve care and control costs. It's becoming a growing percentage of most state budgets. And so that is a legitimate concern. But Medicaid was designed to meet the needs of low-income populations. And so it is understandable that Medicaid is focusing more on health equity, and we've all heard about social determinants. And these are good news for community health workers, because this is an area where clearly people are recognizing that CHWs can make a difference. I will share with you that we are looking towards, hopefully, a change of administrations next month. And I have it on good authority that people in the incoming administration are very interested in community health workers, and they are looking at ways that they can propose to increase the sustainability of the CHW workforce. Some of it is coming out of the COVID-19 response, but it is largely driven by values like health equity and social determinants. The next point, and I talk about this a lot, and it's pretty complicated, but healthcare generally is going through a sea change or a tectonic shift from a system that was mostly transactional, meaning that you need a service, you go to a provider, you get the service, and they get paid somehow. And so it's a transaction each time you as a patient interact with the system. And it is being pushed for a lot of reasons into being more relationship-based. And we hear a lot about medical homes and accountable care organizations and that sort of thing. And those organizations are really being required by the design of the system, the design of their payment structure, to be more relationship-based. And the good news about that, of course, as you've heard from our panel, and many of you well aware of this, that community health workers are the relationship specialist in almost any organization, that they are good at what they do because of their ability to establish trust and improve communication. And if you talk to most healthcare providers, they will, despite the best of intentions, be very frustrated with their ability to communicate with low-income and minoritized populations. And then lastly, and so community health workers, in a sense, are the answer to that dilemma for the healthcare system. And the last point I would make, I finally found a picture of this guy. Willie Sutton was a famous criminal in the 20s and 30s. He was finally brought to justice in the 1950s. And he was asked at one point, why do you rob banks? And his answer was, because that's where the money is. And so the reason we're talking about Medicaid is, should be pretty obvious at this point. But it is also important to remember that just because in Pennsylvania clinical services are paid for in one way doesn't mean that you have to use the same payment methods for community health workers. So if some services are paid for under fee for service, that there are alternative payment models that are used for other services. And so you can end up with a situation where an organization is paid so much per month for each person that's enrolled in the program. And that is not based on how many individual services they receive. It's simply a flat fee that the organization receives. It's important to be clear about who employs the community health workers, and we'll hear a lot about this, but I want to emphasize that a lot of CHWs are and should be employed by community-based organizations, but they're also employed by health plans, local health departments, healthcare providers, federally qualified health centers. And I wish I had more time to talk about these, but there is a small but very interesting phenomenon of self-organized groups of CHWs who contract with a payer or a hospital system to provide CHW-related services or activities. And there are some existing CHW associations in the states that do that. There's an interesting proposal started in California of CHWs organized as independent practice associations, the way physicians do in many cases. There is, I'm running a little behind my time, so I want to move on, but there are also a few in the US and Canada of actual worker-owned cooperatives who are essentially self-employed groups who do this. And then there is, although they haven't implemented it yet, a thing they call pools, which are companies or organizations that are purely set up to offer the services of CHWs. It's important to be focused on what employers really are looking for. One of the things that I've learned of really mostly over the last year is that the employer is not always looking for, I hope you can see my little arrow here, they're not always looking for the full coverage of the cost of CHWs. Sometimes they have support for some of the things that CHWs do, but they'd like to be able to do more. And so they would like for something like Medicaid to provide partial support. And then some of them really would like to say, show me how I can benefit financially and otherwise by using my own money. So show me evidence to support self-funding of CHWs. And then, of course, there's still an alarming number of people who have no clue about how community health workers can help. And so the payers you may be thinking about, the state Medicaid agency, the managed care organizations, some other state agencies and programs, self-financing, as I've mentioned. And in some places, in some places, the United Way is part of the funding picture for CHW programs. I'm not going to spend some time on this in the next slide are the basically the guts of the report that I'm promoting to you here today. Again, it's available on the NACHWA website. But I've provided here 7 basically big buckets of policy options. The first one is big decisions like waivers and state plan amendments I mentioned before, and there are pros and cons to each one. The next one, and Pennsylvania is an example of this, where the Medicaid health plan contracts have either incentives or mandates or at least permission to do some things that that can include CHWs. And so the 2020 standard contract for health plans under Pennsylvania Medicaid includes some things that they are encouraged to do. So Medicaid is actually encouraging the health plans to do more with CHWs. Then in a number of parts of the country, Medicaid health plans are doing good stuff with CHWs on their own without asking either forgiveness or permission, I guess I'd have to say. And they can do almost anything they want. In most of the states, they can do most anything they want as long as they treat it as an administrative expense. The standard is that Medicaid health plans are supposed to spend at least 85% of their premium revenue, on actual patient care. So that means they can do anything they want basically with that 15% that's left over. The rest of these are, I'm going to go through them fairly quickly, but you can read about them in more depth in the report. Alternative payment structures which have been stimulated by healthcare reform, meaning basically that in many cases providers get different forms of payment that are not based on how many services of what kind they provide. And that means they can do what, again, the provider can do whatever they want to within limits with that money. I mentioned internal financing. That is still a lively possibility. Some great things have been done with that, especially in states that still, like Texas, have a lot of uninsured folks. The federally qualified health centers are a real interesting case because they are, in most cases, paid differently from other providers. And we can maybe have a little discussion about that in the Q&A. But they get, again, both Medicaid, not much from Medicare, but Medicaid and some from the Health Resources and Services Administration. And then lastly, a number of organizations, and there's some great examples, including in Pennsylvania, of programs that have woven together a number of different sources of funding so that they are not too dependent on any one of them. And that is that has a lot of merit, and that's where United Ways and others can be part of the picture. So the last thing I want to do is leave you with some general advice on how to engage with, as we've started to hear about this morning, how to engage with payers and potential employers like hospital systems. And I've observed over time that this follows a kind of a predictable arc or pathway. And it does start with awareness, certainly, but that's not enough. You next have to show that this is relevant to them, what we call salience. Why should I be interested in community health workers? How does it relate to my business? The next stage, though, once they see how it might help, is showing how much value or what value it has to them in terms of outcomes, in terms of cost. So this is where you get into the business case and the evidence, which we've heard a number of examples of, terrific evidence of CHW effectiveness and impact. And it no matter how many times you tell people what the research says at a national level from other parts of the country, you'll always run into stakeholders who say, we need to do a pilot here to see if it works here. It's great that it works in California. I want to know that it's going to work in Pittsburgh. Okay, so that's pretty predictable too. And once you get them to commitment, that is not enough. What you really want is follow through, where these stakeholders are willing to persuade other stakeholders who are willing to be champions of community health workers in the long run. So this has been kind of a toe in the water, if you will, about the world of sustainable financing. I've had opportunities to talk about this with folks for a whole day at a time, and even at that, it's too much. But be glad to continue the conversation. So I'm going to turn this back to Michelle and see if we've got some things that that folks want to discuss.
Wonderful. Thank you, Carl. So much information to absorb, and thank you. I did put a link in the chat there to the report. I think that's a wonderful opportunity for us to spend some time offline digging deeper into the subject, and I really appreciate the overview that you provided, and just, you know, having some insights into the different sources and strategies that people might be able to pursue.
Sure.
The there was a question that spoke to the COVID and the CHWs. In one particular area, they said that they had lost their CHWs except for one at the beginning of COVID. And how can they then convince their superior to essentially hire again and to get that the community health workers back into the system where they're most needed?
Yeah, great question. I do know that at the federal level that the Biden team's COVID task force is starting to look at that issue. They are aware that the benefits can extend beyond the COVID response, and I think the key is over and over again. The key is showing not just the impact on the immediate numbers that people are interested in, on successful contact tracing, or increasingly how are CHWs going to be involved in the rollout of vaccinations, because we have not just basic outreach and letting people know that it's available, but getting past misinformation and trust issues on acceptance of the vaccine. And so those are areas where CHWs have a lot to contribute. But it has got to be showing, using the results to convince state Medicaid and other stakeholders of the kind of generic impact that CHWs can have. And if anybody on the webinar wants to contribute something about what they have been talking about with payers or employers about that transition, that would be great.
Yes, certainly. If folks wanted to go off mute and share some insights, we would welcome that, of course. Well, let's see, I have another question. How do we shift to ensure that community health workers are getting paid competitive, livable wages?
Wow, that's a big one. And it is interrelated with sustainability overall. One of the things that you can do, and it may be very helpful at a state level, is find a way to document how many people are leaving the work as CHWs because they need to support a family and they're not making enough. That's a big one, but it's back to the same question. What's the value proposition? The point is, and it really is a core thing, is that it's important or it's valuable to employ community health workers, not because they're paid less than like nurses or social workers. That is not the point. The point is the value that they actually produce. And so this could be outcomes, okay, as we heard about this morning. Or it also can be about increasing the productivity of other personnel. When I got started in this work in 1996, 97, I was working with a hospital here in San Antonio, and they had community health workers supporting a nurse who ran a targeted case management program for improving birth outcomes. So they were basically working with pregnant women or women of childbearing age who might become pregnant. And the nurse was paid on a per visit basis. There was an in-person rate and there was a telephone contact rate. And by having community health workers out in the field, they improved the productivity of the case manager so much that they were able to use that revenue to pay for the community health workers. But they also found that by having the CHWs out in the community, they were identifying more eligible clients for the case manager, to the point that the program grew to the point they had to hire more case managers. And so it really was a huge impact for them, but they were able to see that value.
That's a great example. So, you know, I'm hearing a repeating theme in terms of both the compilation of personal stories and impact, but also the data collection.
Yes.
And those go hand in hand. And so can you talk to us just a bit about the resources available to really think about measurement tools and data collection that help further your cause in making your case?
Yeah, there are a number of documents in the Document Resource Center that I mentioned. I just put the link to the financing report in the chat. There are a number of documents that talk about how to, what kind of data to collect and that sort of thing. There is also a really exciting program called the CHW Common Indicators Project, which is being supported by the CDC as is our work at NACHWA. And you can just do a Google search for, Common Indicators Project. And they are doing some great stuff on standardizing the data that programs collect about the impact of CHWs. And that's really important. The other big one, which requires a lot of advocacy at the moment, is the effort to get community health worker activities into electronic health records, so that you can link patient outcomes and clinical costs to the activities that are being performed by CHWs. There's another a specific initiative that's doing a good job of this, which is the Pathways Community Hub program. And I know they have one or more sites in Pennsylvania. I've actually been working with some of those folks in supervisor training. But that's part of the Pathways model, is to make sure that you are not only gathering information on the impact of CHW activities in a lot of different areas, but also that it is that you're getting that you're showing impact on things besides clinical measures, clinical outcomes. So they're getting data on impact on housing and employment and that sort of thing.
So advocacy has come up as an important component to this work as well. And so advocacy on behalf of the sector in the profession itself. But how often do you see community health workers really getting engaged in the policies at the local level or statewide level that help further community health or environmental health? It speaks directly to bills, pieces of ordinances, legislations, et cetera, that might be there that are really directly impacted with that particular community health workers focus area.
It is important, and it is really important that the core education for CHWs include an emphasis on advocacy. It is also important for employers to understand how valuable it is that community health workers be allowed to focus their attention on advocacy and in an organized way. And we heard Mike focusing community engagement and that aspect of the work of CHWs, because it's not just CHWs being advocates, but CHWs mobilizing the community to advocate for itself. Incredibly important. A lot of the issues that families deal with right now, whether it's things like food insecurity or family violence or street violence or environmental justice issues, these are not things that can be addressed through the delivery of services. The community has to be heard about, a deeper changes in policy, changes in private sector activity, all kinds of stuff. And so, yes, absolutely, that needs to be there. That comes back to my original, one of my original points about basing sustainability on supporting the full range of things that CHWs do.
That's right. Thank you. Thank you. Appreciate that. And I do have a question from our attendees, and it references going back to how Dr. Bryant-Stephens had demonstrated and talked a bit about her remediation funding to accompany their program to really get to the root of the home asthma triggers. The program seems rare. How do we get to more of these?
I'm not sure I'm following the question.
I think what the intent is that that particular program really put together the community health workers' visits to the community, to the homes, identifying the asthma triggers, looking at exposures in terms of environmental health in the home, and then linking that and bringing those additional revenue stream to, for instance, make sure that the basement doesn't have moisture and puts sealant in to prevent mold growth and things of that nature, looking at humidity levels, looking at new roofing and such. But there's a cost with that. Dr. Bryant-Stephens said, that's a $15,000 per household cost. And so the question is that seems like a rare type of program where you've got that significant amount of funding to be able to marry with the community health workers' engagement with the family. And so how do we think about those funding streams to making those particular efforts more common and more the norm as opposed to being the exception to the rule?
Well, I would point to, and there is more research going on this, that Medicaid health plans are themselves willing to pay for more of that. But it is also, they are acutely aware, and we've heard a lot about this from the health plans themselves. I've been working some with Medicaid Health Plans of America, and one of the things they've recognized is that in their efforts around social determinants, it's not enough to screen families and refer families to services. You've got to, they have an obligation to make sure that there is capacity in the community. For example, if you're saying that we've identified issues in the home environment that need to be remediated, that they have, the payer has a sort of affirmative obligation to make sure, however it's done, if it's through grants or whatever, to make sure that programs that offer home repairs are adequately funded to the need. It doesn't do any good to refer people to programs that don't have enough resources. And so they are paying attention to that. And I think that of course needs to be encouraged. And so I think you'll find a fairly receptive audience among the Medicaid health plans in Pennsylvania to that issue.
Thanks for that response. It gets back to the business model and making the case and showing how effective these go hand in hand, certainly.
Right.
And really, at the end of the day, it's looking upstream and how do we get upstream in terms of looking at the preventative strategies. And so that's part of, for instance, our work in the community is how do we put those strategies, whether it's resources and policies and community education all together, and then put those strategies in place so that it's holistic, it's comprehensive, and it's really looking at prevention, so that we can, be in that mindset as opposed to treatment.
Yeah, and for the participants here, a really good resource in terms of strategy, how to move the system upstream is a group called Health Begins. It's just healthbegins.org.
Okay.
And they have a lot of resources and webinars and policy papers and that kind of stuff on that very issue.
We'll put them in the chat. So any final closing remarks? We are near the end of our time here. It's been an incredibly insightful morning and lots of a wealth of information and education shared with all of our audience members. And I think panelists as well as attendees all learn from each other and from this conversation this morning. So any closing remarks, Mr. Rush?
Well, thank you for the opportunity. And again, I encourage everybody to, if you're not already involved in NACHWA, please do visit and consider joining. There are organizational memberships and also ally memberships for individuals who are supporters and allies of CHWs. I would really encourage a continuing dialogue on a regional, let's say, Western PA or statewide on financing approaches. I think that in my experience, and I've been there a couple of times for statewide meetings, that the health plans and the state Medicaid office are very open to creative approaches. I think there's you have an advantage of a high level of recognition of the value of CHWs at the state level. So would really encourage a further organized dialogue about sustainability. But I appreciate very much the value of the panel that came before me, which is talking about why we're all doing this in the first place. So that's what it's all about.
Well, thank you so much for your time and sharing all of your information and expertise with us around this table. We greatly appreciate it and have benefited from the information, certainly. We're excited to be able to bring this forum to everyone today and frankly use this as a jumpstart now for more information, both locally, regionally, and across the state. As Carl, you have mentioned, you've been involved in this for many, many years, and so it's nice to know that we have friends that we can turn to for information and assistance and to guide us along the way. And certainly, Mike, thank you to you and your team for the work that you all do, and the panelists. You are all amazing and have done such incredible work into making our communities healthier places for families and individuals to live and learn and grow. I thank you and commend you for all of the hard work that you do day in and day out. Wanted to thank, of course, Dr. Bryant-Stephens as well, and then closing out to thank you to the Highmark Foundation for supporting this conversation this morning and to giving us an opportunity to help bring this dialogue along across the region and learn from each other. So we have right now on this slide a link, so we want to encourage you, and it's also in the chat, for you to participate in the evaluation survey that has been done at the completion of this. So if you complete that survey, that'll help us in future programming. And you'll also, when you complete it, enter a raffle to win a $25 gift card. So we thank you and encourage you to do that. You also get that as a link from us to each of you. So with that, we will close out. We are actually going to give you a few minutes back of your day to do with it as you wish. Perhaps get lunch and continue on. Make sure that you, again, as our community health workers said, practice self-care. Make sure you're taking care of yourselves so that you can take care of your communities in which you work. So with that, thanks to everyone today who was hugely impactful, and we all learned from you. And we look forward to continuing the conversation in the new year. So with that, we'll close out. Have a wonderful day, everyone, and take good care of yourselves. Stay healthy, stay safe, and have a happy holiday season. Bye now.